Hey guys, welcome back to my channel, The ENT Resident. Today, I'll be doing a clinical case discussion on a very important long as well as short case called as nasal polyp. Now, there are two types of nasal polyp. There's antrochoanal polyp and ethmoidal polyp. Today, I'll be doing a case discussion on antrochoanal polyp. You can also now purchase my notes. I've added the links in the description. Okay, so let's get started with the case. So, Aparna, a 35-year-old female living in Hyderabad, Hindu by religion and a homemaker by occupation, came with the chief complaints of nasal obstruction on the right side for 6 months and nasal discharge from the right side for 4 months. Now, going into history of present illness, the patient is apparently asymptomatic 6 months back when she started complaining of nasal obstruction on the right side, which was insidious in onset, gradually progressive in nature to reach the present state. It increases during expiration and while lying down. There is no diurnal variation, aggravated by cold weather, and it is not relieved on using nasal drops. She is also complaining of right sided nasal discharge since the last 4 months, which is insidious in onset, mucoid in type, non foul smelling, non blood stained, and associated with snoring for the last 2 months. Now, coming to negative history. There is no history of recurrent episodes of runny or itchy nose, watering of eyes, sneezing, no history of bleeding from nose, double vision, chronic irritation in throat, throat clearing, headache, reduced or altered sense of smell, trauma, loosening of tooth, significant weight loss, change in voice, and no history of ear complaints. Coming to past history, there is no history of similar complaints in the past, no history of diabetes mellitus, hypertension, bronchial asthma, or TB, no history of surgeries in the past, or no history of known drug allergies. There is no significant family history. In treatment history, there is a history of usage of nasal decongestant drops. Personal history, sleep is reduced, appetite is normal, diet is non vegetarian, bladder and bowel movements are normal, and there are no addiction history. Now we are gonna discuss in details about every history point that I have just mentioned and what does it indicate towards. Starting with our first chief complaint, which is nasal obstruction on the right side. So the patient has basically presented to you with a unilateral nasal obstruction. So at this point, you would have to think, what are the possible causes of unilateral nasal obstruction? So the causes include antrochoanal polyp, foreign body, which is more commonly seen in children. Even antrochoanal polyp is more commonly seen in children, however, it is also seen in adults. Hypertrophied inferior turbinate, concha bullosa, C-shaped deviated nasal septum, malignancy of paranasal sinuses, JNA. JNA is more commonly seen in adolescent males. Nasopharyngeal carcinoma, rhinosporidiosis, inverted papilloma, Seineke, unilateral sinusitis. So these are all the causes of unilateral nasal obstruction. So these are all the causes that should be coming to mind when the patient has presented to you with a nasal obstruction on the right side. Now, say for instance, in this case, if the nasal obstruction became on both sides, what would that possibly indicate? Assuming that you already know that we are doing a case discussion of antrochoanal polyp, or rather a nasal mass maybe. So the possible causes in this scenario would be that a right-sided mass has possibly extended posteriorly towards the nasopharynx and it has blocked the choana of the opposite side. And that's how what started as a unilateral nasal obstruction could progress to bilateral obstruction. Second reason could be a right-sided nasal mass could be pushing the septum towards the opposite side and hence causing an obstruction on the left side as well. Now, this is the second reason over here. Third reason could be a nasopharyngeal mass could be encroaching on both the choana and blocking it, leading to bilateral nasal obstruction. Fourth reason would be a hypertrophied turbinate on the normal side. And fifth reason could be any other bilateral causes of nasal obstruction. Now we see that the nasal obstruction is gradually progressive in nature to reach the present state. Now, what does gradually progressive indicate? Now, gradually progressive is usually indicative of very benign conditions of the nose, like any benign tumors or polyps. However, rapidly progressive is more indicated of a malignant sinonasal mass. Next, we see that the nasal obstruction increases during expiration and while lying down. Now, what does that mean? Why does the nasal obstruction increase on expiration over here? So, what happens is during inspiration, the negative pressure that occurs in the nose, it can pull the mobile nasal mass backward, and therefore it reduces the obstruction slightly during the phase of inspiration. However, during expiration, the airflow direction changes. Now the airflow is from posterior to anterior, and this pushes the free floating end of the mass forward into the nasal cavity. And this will end up in narrowing the nasal cavity, and it ends up creating a valve like obstruction. This is based on a ball valve mechanism. This is the reason why in a nasal mass, the nasal obstruction can actually increase during expiration. Now, why does the nasal mass increase on lying down? Now, when the patient lies down, what happens is the mass usually falls backward into the guana and the nasopharynx. This leads to obstruction of the airway. This is one reason. Second reason is when you lie down, that it causes venous pooling in the nasal mucosa. And this can further cause mucosal swelling, and it can lead to worsening of the obstruction. Third reason is the mucus may pool more when you are lying down, and hence it adds to the feeling of obstruction in the nose. So these are the three reasons why the nasal obstruction could be increasing on lying down. Moving on, this nasal obstruction, it has no diurnal variation. Now, what does that mean? What does that indicate? When a patient has nasal obstruction, which keeps on changing throughout the day, it usually suggests the fact that the lesion is probably a non fixed dynamic cause of nasal blockage rather than a structural lesion. Now, what does structural lesion mean? Maybe like something like a DNS, or maybe something like a hypertrophied inferior turbinate. Those are structural lesions. But when there is no diurnal variation, what could be some of the possible causes? In this nasal obstruction, it is basically a non fixed dynamic cause, which can include nasal polyp, tumors, foreign body, especially in children, chronic fungal sinusitis. So, no diurnal variation has indicated that this is indeed not a structural lesion, but it is a non fixed dynamic cause of nasal obstruction. Next, we see that the nasal obstruction is aggravated by cold weather and not relieved on using nasal drops. Now, what does that indicate? Why is the nasal obstruction not relieved on using nasal drops? This can indicate that there is a presence of mass in the nasal cavity which does not shrink on vasoconstriction. So, it is possible that this nasal obstruction is not due to allergy, and it is also possible that this is not a case of hypertrophied inferior turbinate, because whenever there is an hypertrophied inferior turbinate causing a nasal obstruction, the obstruction definitely improves on using nasal decongestant drops. So, the fact that the obstruction is not relieved on using decongestant drops indicates that there is no allergic component here and that there is no hypertrophied inferior turbinate. Now let's move on to the second chief complaint, which is nasal discharge on the right side. Now, why is the history of nasal discharge important in a case of nasal obstruction? What could this history point towards? This history will help you in ruling out fungal sinusitis, and it will also help you in ruling out tumors, because tumors usually will have some blood-stained discharge associated with it. Even fungal sinusitis will have some kind of purulent discharge. It can even be foul-smelling discharge. And fungal sinusitis cases are usually commonly seen in middle-aged people. Now let's go more into the details of nasal discharge. I have mentioned that the nasal discharge is mucoid in type. Now that will bring in the question, what are the possible types of nasal discharge and what are the conditions that you would be seeing them in? So there are three total types of nasal discharge: watery, mucoid, and purulent. Now, in this case, we have seen a case of mucoid discharge. So, the causes of mucoid discharges are antrochoanal polyp, allergic fungal sinusitis, choanal atresia, and ciliary motility disorders like Cartagener's syndrome. Some causes of watery nasal discharge would be allergic rhinitis, which is the most common cause, vasomotor rhinitis, CSF rhinorrhea, and ethmoidal polyp. So you can see over here the two polyps have different kinds of discharge associated with it. Antrochoanal polyp has a mucoid type of discharge, which is more indicative of infection, whereas ethmoidal polyp has a more watery discharge, which is more indicative of an allergic cause behind it. And a few causes of purulent nasal discharge would be a long standing foreign body, bacterial rhinosinusitis, atrophic rhinitis, infected polyp, furuncle, and septal abscess. Next is I've mentioned that the discharge is not foul smelling. So that brings in the question, what are some causes where you will see a foul smelling nasal discharge? Some causes would be a foreign body case, which is usually seen in children in cases of atrophic rhinitis. And in atrophic rhinitis, this discharge is foul smelling and it can be actually smelled by all the people surrounding the patient. However, the patient will not be aware of the smell because of his anosmia. And this is why this condition is known as merciful anosmia in this patient. Other causes include fungal sinusitis and myiasis. Discharge is also non blood stained. So that would require you to know what are, if indeed there is a blood stain, what are some causes that could lead to that. So, some causes of blood stained nasal discharge are juvenile nasopharyngeal angiofibroma, a neglected case of foreign body, rhinolith. Rhinolith is basically a stone formation inside the nose around stimulus. There could be rhinosporidiosis, malignancy, atrophic rhinitis, trauma, and Wegener's granulomatosis. Trauma is, however, associated with more frank bleed than a blood-stained nasal discharge. Last of all, the patient has also complained of snoring in the last 2 months. Now, this snoring basically indicates that there is the presence of a significant obstruction in the nasal cavity because of which there is snoring. And as a result of snoring, the patient also is having disturbed sleep. Now, coming to the negative history. Why are all these negative history important to take, and how does each of them help you in ruling out certain diagnosis in this case? So, let's discuss each one of them. First of all, is a history of running or itchy nose, sneezing, watering of eyes. All of these usually suggests an allergic response in the person. And when there is no allergic response present, it usually rules out allergy as a cause for the nasal obstruction. Second, no history of bleeding of nose. So here you would need to know what are some causes where bleeding of nose happens. Like most commonly it happens in malignancy. It can happen in inverted papilloma, which is a locally malignant tumor, other granulomatous diseases of the nose, for example, rhinosporidiosis, rhinoscleroma, TB, lupus, leprosy, trauma, and fungal sinusitis. Next is double vision. Now, when do you see double vision in a nasal mass case? This can happen when there is involvement of the medial rectus in sinonasal malignancy. It can happen in an intraorbital spread of sinusitis. It can happen in cavernous sinus thrombosis, which can be a complication of sinusitis and malignancy. It can also happen with nasal masses, which lead to orbital invasion. So that is why absence of double vision basically rules out all of these causes. Next is chronic irritation in the throat and throat clearing. And, whenever a patient comes to you with a chronic irritation of the throat and hawking, basically they keep on clearing their throat every few minutes, that usually indicates the presence of a post nasal drip. And post nasal drip is most commonly seen in sinusitis. Headache, which is also seen in sinusitis, or it can also include some kind of malignancy. There is no reduced sense or loss of smell. Now, when we talk about smell, what are some terms that you need to know in relation to smell? So, these are all the possible problems that a person can present to you in terms of smell. Anosmia, meaning there is a complete loss of smell. Parosmia means perverted smell, which means that there is an altered sensation of smell. Cacosmia means a feeling of bad smell, which means that every kind of smell is kind of perceived as a bad, foul smelling odor. Hyposmia is the decreased sensitivity to smell, and hyperosmia is an increased sensitivity to smell. Next is trauma. A history of trauma would help you in looking for any kind of underlying nasal fracture, or even a trauma history would also come with bleeding from the nose. Loosening of tooth is more indicative of a sinonasal malignancy, especially the one involving the maxillary sinus. Weight loss, a history of weight loss would point towards tuberculosis or any malignancies. A change in voice. Now, a change in voice can happen when there is two different types of change in voice that can happen. One is hyponasality, which is also known as rhinolalia clausa. Now, rhinolalia clausa is seen when the obstruction in the nose is almost complete. It's almost filling up the nasal cavity, and this can be seen in polyps, adenoid hypertrophy, and nasopharyngeal masses. Whereas the second type is hypernasality, also known as rhinolalia aperta. And this is seen in cleft palate, palatal palsy, and velopharyngeal insufficiency. What is the importance of taking ear history in the case of nose? What can happen is if there is any infection in nose and in the paranasal sinus or in the nasopharynx, it can actually lead to impacting the ear. It can lead to a case of serous otitis media by blocking the eustachian tube. And as a result of which the patient will complain of decreased hearing in that ear, as well as a sensation of fullness in the ear. Secondly, there can be a nasal mass which starts obstructing the eustachian tube and leads to serous otitis media. So, these are the two possible ways how a problem in the nose can also impact the ear. And that is why it is important for you to take history of ear complaints as well, and every time a nose case comes to you. Now, let's discuss about the past history. So, a past history of diabetes mellitus and hypertension. Why is that important? This, first of all, it is very important for a preoperative evaluation of the patient because you also need to see about the fitness of the patient for a surgical case. Secondly, epistaxis is more commonly seen in hypertensive patients. So, you need to be able to control the BP before you take the patient up for a surgery. And it has been seen that in diabetes mellitus patients, fungal infections of nose are more common. This is why you need to take up history whether the patient has diabetes and hypertension. Bronchial asthma. The history of bronchial asthma will help you in pointing towards an associated nasal allergy. And there is a triad that is associated with nasal polyposis over here, which is known as Samter's triad. And this triad is associated with a case of ethmoid polyposis. Next is tuberculosis. In tuberculosis, you can also have tuberculosis of the nose. It is a relatively rare place to be involved in TB, but in general, you need to ask about if there is an evening rise of temperature, a loss of weight, or appetite. And these things can be seen in a case of tuberculosis of the nose. Next, coming to personal history. As I've mentioned, that the patient has complained of reduced sleep, and what could possibly explain that? A nasal obstruction that is happening due to maybe the presence of a nasal mass, and this is causing an obstruction in breathing and snoring, which leads to disturbed sleep at night. Other than that, over here, having no addiction history is a point in favor of this being a non malignant case. Because usually addiction history is more associated with a malignant case. However, it is not a very, it does not mean that if there is no addiction, that there can be no malignancy at all. There can be. Now let's move on to examination of the nose. Let's find out what are the findings that we find once we examine this case. So facial symmetry is present, skin and external osteocartilaginous framework is normal, bilateral ala, columella and both vestibule are also normal. On anterior rhinoscopy, we see that the septum is present on the midline. On the right side, the floor is normal, and we do not visualize the inferior turbinate. But what we see here is a solitary, pale, glistening polypoidal mass which is seen filling the right nasal cavity. It has a smooth surface, mobile, insensitive to touch, it doesn't bleed on touch, soft in consistency, and it can be probed all around. And the nasal mucosa is also congested. And everything is normal on the left side. You can see in the image over here that in the right nasal cavity we see a single pale glistening polypoidal mass. And on doing the probe test, we find that it is mobile, insensitive to touch, doesn't bleed on touch, and it is soft in consistency and can be probed all around. On posterior rhinoscopy, a pale glistening polypoidal mass is seen in the right choana, but the eustachian tube opening is also visualized on the right side, which means that it is not extending into the nasopharynx. The left side is seen to be normal. On examination of paranasal sinuses, there is no redness or swelling. All sinuses are non tender. And on functional tests, we see that on the right side, Cottl's test shows no improvement. Cold spatula test has decreased misting. Cotton wool test has reduced movement, and smell is absent on the right side, whereas everything is normal on the left side. Eye, oral cavity, oropharynx, indirect laryngoscopy, ear, and neck examination are all normal. So, this is the clinical examination findings that you have seen in this patient. Now, let's discuss each point one by one, and let's also discuss what are the possible questions you could be facing at each of those points. Now we have started with facial symmetry. Why is facial symmetry important? It could be important in cases of facial palsy, which where you will see a distinct asymmetry in the face. In the skin of the nose, you should look for scars or sinuses. And in coming to external osteocartilaginous framework. Now, what are some deformities you externally that you see in the nose? And let's discuss a few of them and what are the causes of them. The most common deformity is the saddle deformity of the nose. You can see in the image over here, this is a normal nose. The second one is what is known as a saddle nose deformity. This bend that happens over here, this is what causes it to look like a saddle. A saddle is the thing that you use when you sit on the horse. So, what are some possible causes of saddle nose deformity? It could be post trauma. It could be from iatrogenic causes like excessive septum removal in SMR, septal hematoma or abscess, leprosy, TB, congenital syphilis, sarcoidosis, Wegener's granulomatosis. So, these are all the possible causes of saddle deformity of the nose. You can see in the third image over here, this is what is known as a supratip depression, and this is what is known as a humped nose. Some other deformities are like you can see a crooked nose. The image over here is showing a crooked nose where the midline of the dorsum from the frontonasal angle to the tip is curved in a C-shaped or an S-shaped manner. And that is what is called a crooked nose. Whereas in a deviated nose, you will see in the image over here that the midline is straight but it gets deviated to one side. There is also something known as Hebra nose, which you see over here, and that is seen in rhinoscleroma in the granulomatous stage of the disease. That also reminds me, you should also know the different stages in the progression of rhinoscleroma. Now coming to this case that you see over here on the left side is rhinophyma. And what is rhinophyma also known as? It is also known as potato nose, and this happens because of the atrophy of the sebaceous glands that is present on the nose, nasal tip. There is also another deformity which is known as frog nose deformity. Now, how do you describe frog nose deformity? Where you basically see a elongated protruding nose and a widened nasal bridge. And the most common place where you see it is most common case is juvenile nasopharyngeal angiofibroma. However, the second cause where you also see it, but only in very extensive cases, and that is bilateral ethmoidal polyposis. You can see in the picture over here that this patient has a widened nasal bridge, and the patient is also having a very elongated protruding nose. So these are all the deformities, external deformities, common ones that you could be asked about. Now, as we discussed a little about JNA, can you tell me like what is the sign that you see in CT over here? This sign that we are seeing over here, which is the anterior bowing of the posterior wall of the maxillary sinus. On the right side over here, you see that this is a normal maxillary sinus, and in the left side over here, you see that there is an anterior bowing of the posterior wall of maxillary sinus, and this is known as the Holman-Miller's sign. Now let's discuss the anterior rhinoscopy findings. So we have seen a solitary pale glistening polypoidal mass. So this means that there are no multiple masses, there's only one mass. And a pale glistening polypoidal mass usually points towards the presence of a polyp. And on probe test, we have found a lot of findings. So coming to probe test, what instrument is used for probe test? You should know the name of the instrument, and this is known as the Jobson Horns probe. And what all do you test over here? We test the consistency of the mass, whether the mass bleeds on touch, the sensitivity to touch, and if it can be passed all around and determine the site of origin. So, in the case over here, you can see that the mass is insensitive to touch, which indicates the absence of nerve endings on the mass. It does not bleed on touch, which kind of rules out a lot of conditions, especially malignancy, inverted papilloma, rhinosporidiosis. So the mass must not be a vascular mass. It is soft in consistency. So this will point more towards polyp, and because in cases of inverted papilloma or in cases of malignancy, you will see that the mass is firmer and it is not soft in consistency. And in this case, you see that the mass, the probe test, it can be probed all around the mass, which means the mass is actually not attached to any particular structure. It is not fixed. Usually, probing helps you in determining the site of origin. Say you pass the probe and you are able to pass it all around except superiorly, that is the roof. What would that indicate? That would usually indicate a mass that is coming from the roof of the nasal cavity. Possible answer would be an olfactory neuroblastoma, which arises in the olfactory region. Same way, if the mass is, if you see the mass being coming from the lateral side, and you're not able to pass the probe laterally, it could be possible. One of the possible causes could be a hypertrophied inferior turbinate, because the inferior turbinate is attached to the lateral wall of the nasal cavity. So that is what all the things that you need to see in while doing a probe test, and each of these will help you in coming to your diagnosis individually. Now coming to posterior rhinoscopy, we see that a pale glistening polypoidal mass is seen in the right choana, and the eustachian tube opening is visualized on the right side, whereas the left side is completely normal. Now, what is posterior rhinoscopy? Posterior rhinoscopy is the method of clinical examination by which you are actually visualizing the posterior nares, also known as the choana, with the help of a mirror. And do you know what is the name of this mirror? There is a scientist name associated with this, which is St. Clair Thompson's posterior rhinoscopy mirror. And a very common Viva question over here is to know the size of the mirror. The size of the mirror is 10 millimeter. And you should also know how do we perform posterior rhinoscopy and what is the difference between performing posterior rhinoscopy and indirect laryngoscopy. A very key difference over here that you should remember is posterior rhinoscopy is performed with the help of a Lux tongue depressor. So you depress the tongue with your left hand, and with the right hand you introduce the posterior rhinoscopy mirror. Whereas when you're trying to perform an indirect laryngoscopy, what you do is you hold the tongue and you pull the tongue out lightly, and then with your right hand, you introduce the indirect laryngoscopy mirror. So that is a key difference in the examination of both cases. Now, before you perform the examination, what are some ways that you prevent the fogging of mirror before you introduce into the oral cavity? Because the moment you introduce a cold mirror inside the oral cavity, you will see that fogging starts to happen and you will not be able to see anything. So, there are some ways that you can reduce and prevent this fogging. These can be by dipping the mirror in a warm water, by rubbing the mirror over the flame of a spirit lamp, by rubbing the mirror on surface of the buccal mucosa and generating the heat by friction. This is usually done when you do not have all these other things in the OPD, but you still have to perform the examination. So in that case, you can just rub the mirror on the buccal mucosa and that generates heat by friction and heats up the mirror. You can also dip the mirror in defogging solutions like cetrimide. So these are all the ways you can prevent fogging of the mirror. Now let's talk about how are we going to perform posterior rhinoscopy. Before that, we should know the difference between the two mirrors, common mirrors used in OPD, which is the ideal mirror and the posterior rhinoscopy mirror. The ideal mirror is usually larger in size and it has a diameter of 10 to 25 mm, whereas the posterior rhinoscopy mirror is much smaller. Typically, a 5 to 10 mm diameter is used. A smaller mirror in case of children and a larger size in case of adults. Usually, in adults, we use a 10 millimeter size. Now, the angle of the mirror, as you can see in the image, it is very different. An ideal mirror is straight or very slightly angled. Just the mirror over here gets angled. Whereas posterior rhinoscopy mirror has an acute angle, typically 45 degree to 60 degree, so that this angle helps you in visualizing the posterior nares of the choana. And the ideal mirror usually has a smaller shaft and the posterior rhinoscopy mirror has a longer shaft. Now let's talk about how do we perform posterior rhinoscopy. As I said, first you need to warm the mirror so that you do not face any fogging when you introduce the mirror into the oral cavity. And once you have warmed the mirror, you should also test it first on the flexor aspect of the wrist before you put it into the mouth, because what if it is too hot and if by mistake it touches any mucosal surface, it may cause inconvenience to the patient. So after you have done that, first you depress the tongue with the help of a tongue depressor. Now the instrument used over here is known as the Lux tongue depressor. You use it with your left hand, and then the mirror is introduced with your right hand into the oral cavity. It is passed behind the soft palate, and you should try to avoid touching the uvula and any surrounding structures because that can lead to gagging and you will not be able to examine the patient. Now you should instruct the patient to breathe through the mouth. They should definitely not breathe through the nose, because once the patient breathes through the nose, the soft palate starts elevating and it closes up the nasopharynx, and hence in that case you will actually not be able to see the nasopharynx and the posterior choana. So, in order to perform the posterior rhinoscopy examination, it is very important to instruct the patient to breathe through the mouth and not at all through the nose. When you are breathing through the mouth, the soft palate starts relaxing and it starts moving forward and downward. And that will create more space in the oropharynx, which makes it easier for you to introduce the mirror and see the structures. Now, next we need to know what are the structures that you will be seeing when you perform posterior rhinoscopy. And this usually you should actually draw a diagram, label diagram showing what you have seen. Now the structures that you will be seeing are, first of all, anteriorly, you will see the posterior end of the nasal septum. And this is the first structure that you will be seeing. And this will help you in orienting yourself to the anatomy. Now, once you have found out the posterior end of the nasal septum, you will be able to see the posterior end of the middle and inferior turbinates on both the side and the posterior end of the superior turbinate. This is the highest landmark, and obviously it is a very difficult landmark to see. You will also be able to see the posterior part of middle and superior meatus and the nasal surface of the uvula and the soft palate when you tilt the mirror a little bit. So these are the structures that you see anteriorly. Now laterally, you will see eustachian tube openings. If you see over here in the image, this is the eustachian tube opening. And this is on the left side. You can see the eustachian tube opening on either side with tubal elevation just behind the posterior end of the inferior turbinate. And behind the eustachian tube opening, you can also see the fossa of Rosen-Miller. But this is a much more difficult structure to identify. And superiorly, you will see the roof of the nasopharynx, and this is where at the junction of the roof and the posterior wall of the nasopharynx is where you should be looking for adenoids. And this is very important in cases of children who come to you with mouth breathing and snoring, and they end up being cases of adenoid hypertrophy. You can also see the superior part of the posterior pharyngeal wall. So these are all the structures you can see when you perform a posterior rhinoscopy. And this is very difficult to perform for an undergraduate usually. And the examiner will usually not expect the findings from you. However, you should definitely know what are the structures that you see. Next, coming to paranasal sinuses. We have seen that all the sinuses were non-tender. Now that will lead to the question, where do you check for tenderness for each of the sinuses? Coming to frontal sinus first, you will check for tenderness below the medial end of the eyebrow, which is the floor of the sinus superior to the medial canthus. And why do we check it here? Because the bone of the frontal bone is over here very thin, the frontal sinus bone. And because the bone is thin over here, it is much easier to palpate over here and find your findings. And this is also the dependent part of the sinus. Secondly, for ethmoid sinus, you will check medial to the medial canthus in the medial orbital walls. And for maxillary sinus, you will check in the canine fossa over here. And when I was telling you about the ethmoid sinus, here we are mostly checking the anterior ethmoid sinus. Posterior ethmoid sinus is much deeper in location and it is not palpable. And another sinus which is not palpable is the sphenoid sinus. So when you are actually checking for sinus tenderness, you should mention that you are checking for frontal, anterior ethmoid and maxillary sinuses only. You cannot comment on posterior ethmoid and the sphenoid sinuses. Now, we have spoken about that. If we had to check about maxillary sinus, we have to check in the canine fossa. Now, that will bring up the question of what are the boundaries of canine fossa? Now, you can see the boundaries. This is the image over here. This is the canine fossa. It is bounded by the infraorbital foramen superiorly, the alveolar ridge inferiorly, medially by the piriform aperture, and laterally by the canine eminence. These are the boundaries of canine fossa. And what is the importance of this fossa? First of all, you can check for maxillary sinus tenderness here. And secondly, this is also the fossa through which you perform the Calvel Lux surgery. Next, do you know the other name for maxillary sinus? It is also known as the antrum of Highmore. Now coming to functional tests. We have seen that on the right side, Cottel's test leads to no improvement. The cold spatula test has led to decreased misting. There is a reduced movement on cotton wool test and an absent smell. Now all of this indicates that there is a possible obstruction in the right nasal cavity. We have seen that all these examinations are normal, but we should also know what is the importance of this. So the importance of oral cavity and oropharyngeal examination in a case of nasal mass, unilateral nasal mass, here that sometimes what happens is a AC polyp, the guanal part of the AC polyp can actually grow further backwards and it can hang in the oropharynx. When you're examining the oropharynx, it is important to see if there is a mass coming on from the nasal cavity into the oropharynx. Secondly, a very large AC polyp can actually obstruct the movement of the soft palate and it can cause velopharyngeal insufficiency. Next, what is the importance of ear examination in these cases? I've already mentioned the reasons why you need to be taking the history of ear complaints from this patient. It is those same things. You should see whether there is a mass in the nasopharynx which might be occluding the eustachian tube, or if there is an infection in the nose or the nasopharynx, that can also lead to occluding the eustachian tube. Next is neck examination. The importance of neck examination here would be that if it is a case of sinonasal malignancy, it can actually spread to involve the cervical lymph nodes. So if there is a cervical lymph node enlargement, it will help you in pointing more towards malignancy than a benign case like polyp. Now that we have discussed all of the history and the clinical examination, now let's first summarize the case and then we'll talk about what is the provisional diagnosis and what is the differential diagnosis. So, here a 35-year-old female has come with the chief complaint of right sided nasal obstruction for 6 months and discharge from the nose for 4 months. And this right sided nasal obstruction was insidious in onset, gradually progressive, increases during expiration and lying down. There is no diurnal variation, aggravated by the cold weather, and not relieved on using nasal drops. The nasal discharge from the right side is insidious in onset, mucoid in type, non foul smelling, non blood stained, and associated with snoring for the last 2 months. And on examination, we see a presence of a solitary, pale, glistening polypoidal mass seen filling the right nasal cavity, which has a smooth surface, mobile, insensitive to touch, doesn't bleed on touch, soft in consistency, and it can be probed all around. Uh, you can ignore this. This is actually wrong. It can be probed all around. Nasal mucosa on the right side is congested. Posterior rhinoscopy has revealed a pale glistening polypoidal mass seen in the right choana. Eustachian tube opening has been visualized on the right side. Cotton wool test shows reduced movement on the right side. Whole spatula test shows reduced misting, and smell is absent on the right side. So, from all that summary, now what is your provisional diagnosis? So, diagnosis over here is a right sided sinonasal mass, likely an antrochoanal polyp. Now, the moment you mention your provisional diagnosis, the next question that will come to you is what are the points in favor for your diagnosis? So, first of all, let's talk about history. From history, we find out that this is a case of unilateral nasal obstruction, which is gradually progressive in nature. Secondly, we find out that the patient has also come to you with a mucoid nasal discharge. And this mucoid nasal discharge, it is not foul smelling and it is also not blood stained. So these are important history findings. Secondly, the patient has no allergic history and also there is no history such as suggestive of malignancy like diplopia, bleeding, loosening of tooth and etc. And now, when you come to clinical examination, we have seen that this is a case of solitary pale glistening polypoidal mass. This is a very important factor pointing towards AC polyp. And this mass has a smooth surface, it is mobile, insensitive to touch, doesn't bleed on touch, and soft in consistency, and we can probe all around it. All of these features are pointing towards polyp, and more significantly, antrochoanal polyp because it is a single large polyp that we are seeing over here. Next, we also see that the mucosa is congested, which is more pointing towards an infective etiology, and the mass has been seen to be extending into the choana, which is a very common presentation if there is an enlarged antrochoanal polyp. So, all of these points are all pointing towards a case of antrochoanal polyp, and it is ruling out any case of malignancy or any other kind of mass. Now, that will bring you to the point of what is the definition of a polyp? How do you define polyp? Polyp can be defined as inflammatory, non neoplastic, hypertrophied, edematous mucosa, which is prolapsing out of the nose and the paranasal sinuses. This is very important for you to know. This is a 100% definite question you will be asked if you get a case of nasal polyp. Next, now we have talked that this is a antrochoanal polyp. Now, what are the different parts of antrochoanal polyp? We know that antroconal polyp is actually trilobed in shape, as you can see in the image over here. And it has three parts. First of all is the antral part, which is the first part to develop, and this develops in the maxillary antrum. Second is the nasal part, which is actually the smallest part present in the nasal cavity. And the third part is the choanal part, which is the part which is seen in the posterior nares and extending into the nasopharynx. So these are the three parts of the antrochoanal polyp. Next, a very, very, very important question if you get a case of antrochoanal polyp is why does the antrochoanal polyp grow backwards rather than forwards? And there are multiple reasons for this. First important reason over here is that the mucociliary clearance of our sinuses, of the ciliary movement of the nasal mucosa, it is actually directed towards the posterior choana. This is a very, very important reason. The second important reason is that the inspiratory current is usually way stronger than the expiratory current. And because the direction of inspiratory current is from anterior to posterior, this creates a negative pressure and pulls the polyp backwards. So these two reasons are the most important reasons and the first 2 points that you should be mentioning when you are asked this question. Other more less important reasons over here would be that the floor of the nasal cavity slopes backwards. The direction and opening of the maxillary sinus is directed back downwards and backwards. There is also the question of gravity over here. And last of all, there is more space present posteriorly than in the anterior region of the nose. So these are the 6 reasons why an antrochoanal polyp grows backwards rather than forwards and coming out of the nasal cavity. And out of them, the first 2 reasons are the most important ones. Now we have said that usually antrochoanal polyp does not come to you with blood stained discharge, and we have already talked about all the other causes of blood stained discharge. But can an antrochoanal polyp ever cause a bleeding? It can, but it is very, very rare, and that there are 3 possible reasons for it. So when an antrochoanal polyp has grown very large and it gets exposed to the environment through the nostril, there are certain secondary changes which start happening on the surface. First of all, there can be a chronic irritation or pressure, and it can lead to ulceration and bleeding. Secondly, the infected polyp can actually become hyperemic and fragile, increasing the chance of bleeding. Thirdly, there can be squamous metaplasia happening on the surface due to the air current exposure, and that can lead to the formation of an angiomatous polyp. Now, we have discussed about what is a provisional diagnosis. It is a right-sided sinonasal mass and antrochoanal polyp, and we have discussed a few viva questions related to antrochoanal polyp. Now we next need to discuss about what are the differential diagnoses in this particular case. And the differential diagnoses include inverted papilloma, rhinosporidiosis, malignancy, allergic fungal sinusitis, meningoencephalocele, inferior turbinate hypertrophy, rhinolith, and foreign body. Now let's see why is it not any of these cases that we are mentioning as provisional diagnosis and what are the particular features we'll be seeing in each. And that itself will help you understand as to why this is a case of antrochoanal polyp and not any other such causes. First of all is inverted papilloma. Now, inverted papilloma is more commonly seen in middle-aged males, and there is a more rapid progression of the nasal obstruction, and it's usually not gradual. We see a history of bleeding over here because the mass that you see over here in the picture over here, it is a very soft pinkish or grayish fleshy mass which is friable, definitely bleeds on touch, and it is insensitive to touch. So the mass being friable and bleeds on touch is what makes it different, and it is also a soft pinkish or grayish fleshy mass. These are what differentiates it from a AC polyp. This has kind of a granular mulberry-like appearance, and the most common site from where it originates is the lateral nasal wall in the middle meatus. Next one is rhinosporidiosis. Over here we see a pinkish reddish mass studded with white dots on the surface, which gives it a very strawberry like appearance. And the white dots are usually the sporangia in this case. And this mass usually bleeds on touch because it is a very vascular mass. Also, there can be a presence of granulation tissue. This mass is also very friable. So these are all the features you see in a case of rhinosporidiosis nasal mass. Next is a case of malignancy of the sinuses or the nose. Usually, these are patients in the older age group, more commonly seen in males. They can present with a addiction history or even some occupational history of them being working in the nickel industry or the furniture industry. And these cases are always rapidly progressive in nature. And you can see in the image over here that you can describe the mass over here as irregular pinkish grayish mass with everted margins. And these masses are also friable and it can bleed on touch, and it is definitely sensitive to touch and firm in consistency. All of these features over here are pointing towards a malignant nasal mass rather than a benign mass, and it can also have ulceration on it. So, these are all the features that you see in a malignant nasal mass. Next is a case of allergic fungal sinusitis. If you see in the image over here, we can see the presence of some sticky nasal, thick, sticky nasal discharge. This is known as allergic mucin, which is a very important feature that we see in these cases. So the patient will come to you, the patient will usually be a very young patient, and the patient will come to you with a unilateral or the bilateral nasal polyposis with thick, sticky yellow-green mucus. This is known as peanut butter mucus or allergic mucin. Next is a meningoencephalocele. Now, what are the differences you will see in a case of AC polyp and a meningoencephalocele? Meningoencephalocele is usually a herniation of the meninges and brain tissue coming through a skull base defect, whereas a AC polyp will arise from your maxillary sinus. A meningoencephalocele is bluish, cystic, or pulsatile, and it may also be translucent, whereas a AC polyp is smooth, pale, glistening, and polypoidal. There is a significant difference in how it appears. A meningoencephalocele it is soft or cystic in consistency, which is similar to that of AC polyp. However, it can be pulsatile or reducible, but AC polyp will not be pulsatile or reducible. And when we perform the CSF leak test or a Valsalva, the meningoencephalocele can expand, and this it can also present with CSF rhinorrhea because of the leak, because of the skull-based defect through which the CSF leaks out. Whereas this test will be negative in an AC polyp. On performing the probe test in an AC polyp, you will see that it does not pulsate, it is insensitive to touch, does not bleed on touch, and is also not transilluminant. Whereas meningoencephalocele, you should try not to perform the probe test if there is a high suspicion for it. But it in this case, if you do perform it, it will be sensitive to touch, and we'll also see a positive Furstenberg test. Now, what is the positive Furstenberg test? Usually, we see infants or children coming to us with these cases. When the infant cries or does any kind of straining movement, it leads to expansion of the mass. Lastly, on radiology, we will see that the AC polyp is a mass which is arising from the maxillary sinus and extending into the choana, whereas a meningoencephalocele, we will see that there is a skull-based defect and a herniation happening from the brain into the nasal cavity. So these are all the differences between an AC polyp and a meningoencephalocele. If you see in the image over here, on the one on the left side is an AC polyp. You can see that it is arising from the maxillary antrum on the right side, and it is extending into the nasal cavity. Whereas on the right sided image over here, we see that there is a skull based defect over here and the herniation of the brain tissue along with meninges happening inside the nasal cavity. This is the difference in how the appearance is in a CT scan. Next is a case of inferior turbinate hypertrophy. Now, inferior turbinate hypertrophy is usually a very soft pinkish mass you can see in the left-sided image, and it arises from the inferior part of the lateral wall of the nose. Very important distinction here that this mass will always shrink on using vasoconstriction, which is the nasal decongestant drops. This mass is not mobile, it is soft to firm in consistency, and it will be sensitive to touch because of the presence of nerve endings. The right side image over here shows this right-sided inferior turbinate hypertrophy. You can see that this is the inferior turbinate bone and this is the mucosa which has undergone hypertrophy. Next is a case of rhinolith. Now, this is a differential diagnosis which is way down in the list. This should not be the first point that you mention, but only if your examiner asks for more differential diagnosis is when you should mention a case of rhinolith. And in rhinolith, you will see the presence of a grayish brown or a greenish black mass which has a very irregular surface. And the very distinct feature over here that it will be very stony hard in consistency. This is the most differentiating feature that you will be seeing. And it is usually present between the septum and the turbinates. It is very brittle. So whenever you try to manipulate around the mass, it will actually break off and a part of it will come out. So these are all the points that will take you towards the diagnosis of rhinolith. Now, a foreign body nose should be suspected when a child comes to you with a case of unilateral nasal obstruction presenting with a foul smelling purulent discharge, which can also be blood stained. The first suspect you should have is that this could be a case of foreign body in the nose. So that finishes all our differential diagnosis. So we have discussed about the provisional diagnosis and the differential diagnosis. Now let's discuss how are we going to manage this case. So when you're asked about the management of the case, something that you need to remember is we always kind of start answering saying that okay, we will treat the patient in now 1 2 3 these different ways. But the very important thing to remember here is the management will always consist of two parts. First part is investigations and then there is treatment. So first let's discuss what are the investigations we'll be doing. So the first investigation is all the routine blood investigation. This is mostly from the perspective of preoperative evaluation of these patients. Second, we'll perform a diagnostic nasal endoscopy. Why do we perform a diagnostic nasal endoscopy? So that we can see the origin of the polyp and the extent of the polyp, if there is any other additional pathology present, and if the discharge can be sent for if you find any kind of discharge in the nasal cavity, you can send that for culture sensitivity. And if you find any fungal hyphae, it can be sent for a KOH mount. Lastly is a CT scan of the nose and paranasal sinuses. And this we should get all the three views, which is coronal, sagittal and axial views. And what will this help you in? This will help you in seeing the extent and origin of the polyp. It will assess the invasion of any surrounding structures and any anatomical deformities like a concha bullosa or a Haller cell. Okay, so these are the three important investigations that you have done. Nowadays, since there is a presence of CT scan, which is a way better investigation than X-rays, we usually do not perform an X-ray. But earlier, X-rays usually used to be commonly performed. Now, if we had to perform an X-ray for such a case, what is the view that you would be using? So we would be doing an X-ray of the paranasal sinuses in the Waters view, which is also known as the occipitomental view. And this is what the Waters view X-ray looks like. And when you see this, we usually start the way to find out any pathology is to compare the opacity of the orbit to that of maxillary sinus. If you see that the opacity of the maxillary sinus is more than orbit, it is indicative of the presence of a pathology. This is what this X-ray looks like. So these are your orbits. This is your maxillary sinus over here. These are the ethmoid sinuses and these are the frontal sinuses. And you can see that there is a sphenoid sinus over here. And on the sides over here, you can also see the mastoid air cells, which is less important. And let's look at some X-rays and some of the pathologies of maxillary sinus. On the left side over here, you can see acute maxillary sinusitis, where the feature that you'll be seeing is a presence of an air fluid level. You can see that this is the maxillary sinus, and you can see that this is the presence of an air fluid level over here. Whereas in chronic maxillary sinusitis, you will be seeing that there is a complete opacification or mucosal hypertrophy inside the maxillary sinus. You can see on the left side over here, there is a complete opacification, whereas on the right side, it looks more normal. And in case of a polyp in the maxillary sinus, it will have a very typical feature where you can see that there is actually a polyp formation inside the maxillary sinus. Now let's come to treatment of the case. How are we going to treat this case? So we'll perform a surgical treatment over here. We'll perform functional endoscopic sinus surgery. So when you say that, yeah, I'm going to perform a surgery in this case, you'll be asked like, why not first try medical treatment on this patient? So your answer should be, first of all, because this is a case of antrochoanal polyp, no medical treatment will actually cure the disease, because this is not an allergic etiology, but this is rather an infective etiology. And you have to explain to the patient what is the pathophysiology of the disease, and explain to them why no medical treatment will not work over here, and what are the possible, in case surgery is the patient goes forward with the surgery, what are the outcomes they would be expecting from it, what are the possible complications they would be expecting. Next, the next question that you will be asked is, what is FES? What is functional endoscopic sinus surgery? It is a minimally invasive surgical technique which is used to restore normal drainage and ventilation of the paranasal sinuses by removing the obstructive pathology under endoscopic guidance while retaining as much healthy mucosa as possible. So this is how you define FES. Now, that will bring you to the next question as to what are the indications of FES. The indications include chronic rhinosinusitis, which is unresponsive to adequate medical treatment, recurrent acute bacterial sinusitis, nasal polyposis, it could be AC polyp, it could be an ethmoidal polyp case, allergic fungal sinusitis, mucocele or pyoceles, foreign body removal from nose, fungal ball removal, control of epistaxis by endoscopic cautery, orbital decompression, and endoscopic endonasal dacryocystorhinostome. Next, let's talk about, in this particular case, what are the steps we will be performing while performing the surgery. So, first of all, we will perform a polypectomy, which involves the removal of the nasal part of the polyp that you see. So we excise the nasal and the choanal component of the polyp using a microdebrider or a Blakeslee forceps. This will first improve your access and visualization of the nose and paranasal sinuses. Second step would be to perform an uncinectomy, where we remove the uncinate process to expose the natural maxillary ostium. Now, once we have identified the maxillary ostium, next we need to perform a wide middle meatal antrostomy. As we widen the natural maxillary ostium, it will allow complete visualization and access to the sinus cavity. And once we have access to the sinus cavity, we will remove the rest of the polyp, which is the antral part of the polyp. And this is usually attached to the posterior lateral wall. And usually, to perform this step, we use angled scopes, which can be a 30-degree or a 70-degree endoscope, and a microdebrider for better visualization. And as much as possible, you should not disturb the healthy mucosa around, because the moment you destroy the healthy mucosa, it can lead to other complications, which include the formation of synecdoche. So you should try to preserve the healthy mucosa as much as possible. Lastly, after you have removed everything, you examine the case for any residual polyp tissue, and you suction out debris and ensure that the ostium has maintained its patency. And after that, you perform a nasal packing of the case and finish up the case. So these are the steps of FES that you will be following in the case of antrochoanal polyp. So, when you perform an uncinectomy, what are the possible instruments that you can use for it? So, conventionally, when we used to perform uncinectomy, it would be with the help of sickle knife and Blakeslee forceps. Or it can also be done through reverse cutting by using a backbiting forceps. However, in today's times, there is surgeons have been using more microdebrider, because it gives you much better results. Next, let's talk about what are the possible complications of FES. This is also a very important question. You should at least know a few of the complications under each heading. So, when we talk about complications of FES, first you divide them into minor and major complications. Now, minor complications usually involve the intranasal complications like bleeding, synecdoche, crusting, and osteitis. Now, major complications they can further be divided into two. orbital complications and intracranial complications. Now, orbital complications involve periorbital ecchymosis, orbital emphysema, nasolacrimal duct injury when you encroach the inferior meatus, intraorbital hematoma, extraocular muscle injury or entrapment, direct optic nerve damage. Whereas intracranial complications are CSF rhinorrhea because of an injury to the cribriform plate, pneumocephalus, injury to great vessels or hemorrhage, meningitis, brain abscess, encephalocele, frontal lobe damage, and anosmia. So, this table is very, very important from your Viva perspective, and you should definitely remember the whole of it. Next, what is the most dreaded injury in FES out of all these complications that we have seen? The most dreaded injury is actually injury to the optic nerve and the internal carotid artery. And the most common extraocular muscle which gets injured in FES is medial rectus, and the second most common is the inferior rectus. And last question, one tiny question, let's discuss before the advent of functional endoscopic sinus surgery, what was the treatment modality which was used? At that time, the operation for this was Caldwell-Luck operation through a sublabial approach. This operation was also known as anterior antrostomy. Now, this operation, we have discussed the canine fossa earlier and the boundaries of canine fossa. This is the canine fossa. And this canine fossa is through which we perform the Caldwell-Luck procedure. Lastly, you should also know what are the few indications of Caldwell-Luck operation. These include chronic maxillary sinusitis, which is not responsive to treatment, recurrent AC polyp, fungal sinusitis, maxillary sinus neoplasm, oroantral fistula. It can also be used to gain access to the orbital floor when there is a fracture, removal of foreign body in the maxillary sinus, mucocele or retention cyst, dental cyst, fracture of maxilla or blowout fractures of the orbit, and Vidian urectomy. Now, this completes our discussion, our case discussion on antrochoanal polyp. If you have any questions, please comment down in the comment section and I'll get back to you. And in my next video, I'll be discussing a case of bilateral ethmoidal polyp. See you in my next class.